So we've heard a lot about vaccine hesitancy, especially as it relates to COVID-19 vaccine. At Pfizer, we know that every new vaccine is only good for public health if the public trusts that it's safe and utilizes the vaccine. To that end, we've worked hard to be as transparent as possible throughout the process of developing the vaccine. We will continue to do so as we move forward. And while we're moving at the urgent pace due to the serious pandemic, we are not cutting corners. The science and scientists are guiding this process.
Welcome to State of Reform's virtual series, 5 slides we're discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to this virtual conversation hosted here by State of Reform. My name is DJ Wilson, one of the hosts here at State of Reform, covering the healthcare politics and policies of the sector and, of course, the market activity in California healthcare. And really appreciate you all being here with us today. We've got a pretty cool show, I think, that is going to be very smart and, of course, timely, and it's going to cross a wide range of relevant topics, both to healthcare, but also to this time in healthcare. And we're super honored to have some of these folks here with us. I want to just say first, thank you to sponsors like Pfizer. You saw the message from David here that teed this up. They're one of our sponsors across much of our work here at State Reform, and particularly to HealthNet, because this conversation today would not have been possible without HealthNet in California pulling this together. And so, Brian Turnan, President and CEO of HealthNet, I just want to introduce you first, sir, and say thank you very much. Tell us a little bit about the work that you do at HealthNet.
Yeah, thank you. So HealthNet is one of the largest managed care plans that serves the Medi-Cal population in California. So we've got almost 2 million members in California, and proud to serve that population. Yeah,
great stuff. And Dr. Janine Barra, the Chief Medical Officer at WellSpace Health, I appreciate you being with us, ma'am. Tell us about what you do at WellSpace.
Well, thanks for having me here today. WellSpace Health is one of the largest federally qualified health centers in the Sacramento region. We call ourselves actually a health system because we have over 31 sites that provide care to our community, and about 100,000 of those patients. A great proportion of those are HealthNet patients, so we work along really closely with HealthNet and get a lot of support from them. For those who aren't familiar with what an FQHC is, it's a nonprofit community health center that provides care to people regardless of their ability to pay. We offer a full spectrum of care, from primary care for adults, for children, pediatric dental, integrated behavioral health. At WellSpace Health, we also deliver the largest number of babies born on Medi-Cal. We have an excellent program called ONC that was developed and focuses on decreasing maternal mortality and also decreasing infant mortality amongst African American women and babies. And so we're very proud of that program. We also do drug and alcohol treatment as well, and we have many other co-located programs like in the jail or in certain hospital systems, all to provide a blanket of care to those who need it the most.
Yeah, great stuff. And Dr. David Carlisle, the President and CEO of Charles R. Drew, University of Medicine and Science. Sir, thank you for being with us. Tell us a little bit about your work and Charles Drew University.
Sure, DJ, and thank you very much for the invitation. It's great to be here. And Brian, thank you to HealthNet for all the support, not just of this event, but for our university. We recently received a HealthNet grant for telepsychiatry training. And one of the things that we're very happy to be doing now at CDU is we've returned to graduate medical education. We have a psychiatry residency program, a family medicine program, and we're starting an internal medicine residency program. We are a health profession school located in South Los Angeles, and we're in our 55th year. We've been ranked as the number 2 most diverse school in the country, private not-for-profit 4-year, in terms of student diversity, number 1 in terms of faculty diversity, and also ranked as number 3 in the country as a value-added university. And our mission is really taking young people from under-resourced communities and populations and turning them into highly successful health professionals by the midpoints in their careers. And that's what we've been doing for 55 years.
Well, it's a great story. I appreciate you being here and telling it. And let's just jump right in. I want to tee up this first slide. The idea, the structure of our conversation here today of 5 slides is that you have brought each a slide that will contribute to the conversation. We've brought 2 of them from our team at State Reform, and these are things that we think are sort of interesting and big ideas to grapple with and tee up and kind of wrestle with together in conversation. I want to be able to integrate your questions from our audience so that you can pose questions as well and get those into the mix, and we'll try to make sure we make time for those. This first question, or this first slide rather, connects, I think, 2 threads. On the one hand, when we look at the public opinion around the murders of African-American men by police this last summer and the elevation of the Black Lives Matter movement, we saw a transcendence across demography. Saw a lot of people out across different age groups and a lot of people out, particularly in the white community. Some reporting on that that we linked to at the bottom there at the Boston Globe. And it struck me that it was similar to the shift in public opinion during the late first decade, the aughts, and then early teens, when public opinion around gay marriage shifted rapidly. And it shifted mostly because white straight people came to the conclusion that gay marriage was something that was a basic human right. So I'm wondering, I want to ask you all, and Janine, let me ask you first. I'm wondering, does this movement, the Black Lives Matter movement, and this moment rather, is it changing the conversation? Is it like, are we in a different moment where public opinion is moving rapidly in a direction that will impact the way that health policy and healthcare operates?
I definitely think so. We are at a tipping point where we're able to talk about things and say things we couldn't before. We're also having more people, like you're showing on the slide, who are getting involved who aren't Black or African American or who aren't brown. And you see people thinking and feeling and wondering what it must be like to have experienced centuries of racism and degradation up until the continued killing of Black men by our police force. And I really think that with George Floyd, it's been heard, enough is enough. I guess we thought we came a long way with Barack Obama being nominated president, and that is phenomenal and amazing. And now to talk about it for like the average person and to have people really feeling this, when we see those images, we cannot deny them. And that is, I think, the thing that also has really brought this forward is we're not just hearing it or reading about it, we actually saw it. And when you see something, you can't unsee it. And then I think a lot of us feel motivated who aren't Black to do something about it. And I think that this is, and I'm really happy to be able to work along this at this time to try to really grab hold and make the changes that we need to truly have equity in this country. We have an opportunity and we need to keep moving forward with it to help people really understand that we're all basically the same on the inside. But of course, we look different on the outside, but we shouldn't be treated differently.
David, what do you make of this moment and whether it's having an impact on public policy and how the market is behaving?
Well, I think the answer is yes. I think that we have we've achieved maybe a new level of kind of almost enlightenment or sophistication when it comes to the social dynamics that we're talking about. And this is a very good place to be. I think it's part of a trend in American history that is moving in the right direction over time. All right, the trajectory is positive, but we need to make sure that this trend is sustainable. And I know we have some significant events from January 6th that we're all well aware of. These are kind of forces in the opposite direction. I think this is a very good metaphor for the challenges that we face in healthcare, because really and truly, it is the most under-resourced segments of our population that are the most challenged in our healthcare system. And those challenges are manifesting themselves in the outcomes of our healthcare system. So I think this is a great way to open this discussion, and I think that it's a step in the right direction.
Brian, how have you seen, running one of the largest Medi-Cal plans in the state, as you mentioned, how have you seen the healthcare sector, maybe specifically the Medi-Cal line of business, shift as a result of the Black Lives Matter movement?
Yeah, I'd say a couple things. I agree with the comments I've heard so far, and what Dr. Barra was referring to is within our company, from our CEO, Michael Nydorf, on down, within weeks, maybe a week of the George Floyd incident, we had a national call that he called it Courageous Conversations, and really set the tone for the whole company. And now we're having them locally in each of our states. Again, these are internal calls where we are talking to each other as leaders and as frontline employees. And we've got some outside experts that have joined us on those. And it's just a very different conversation. A lot of things that prior to this, the impression was you don't talk about this stuff at work. We're encouraging people to talk about it, to get it out in the open, and let's learn from each other, and let's get, better at understanding. And then we're spending a lot of time, as we have for years, partnering with community-based organizations that are really on the front lines, that understand their community, and listening to them, and really asking, how can we help? How can we make things better? So I think as a company, that's really what we've been focused on, for some for quite a while, and then some are really recent developments.
Yeah, I have been reminded, and I guess I learned this framing throughout this last year, that if you are not uncomfortable, then you are not growing, that it's in discomfort where the growth actually takes place. Brian, let me ask you to walk us through your slide that you've contributed to this conversation, titled Partnering to Improve the Workforce. Tell us what you have going on with this slide.
Yeah, thank you. So really what this slide focuses on is some of the work that HealthNet has been doing around this serious issue of workforce shortage in the healthcare industry in California. So this was an issue well before the pandemic hit. But it's an issue that's particularly important to us because it impacts our most vulnerable patients in California. As the healthcare workforce shortage takes root nationally and in California, it disproportionately impacts certain regions of the state that are already underserved. So, we know the reasons for this. The key issues behind it are that there's increased stress due to the physician shortage and growing demand of patients. This results in negative health outcomes due to the pressure on physicians and healthcare workers. And the fact is that a third of California's primary care physicians and nurse practitioners are age 55 or older. So, it's going to take some real work here to attack this. So last October, we released a comprehensive workforce development report. And a lot of these findings came from community organizations with whom we had partnered and provided grants to. And we studied the outcomes of the programs that we had funded with them. And what we found was there's really three critical focus areas. The first one is the need to identify new talent pools to go into high schools and colleges and encourage folks to consider healthcare as a profession. And we need to do that proactively. It's not just going to happen organically. The second is the need to provide upward mobility at all levels. So a lot of folks might go into this field, but if they're not feeling that they're growing and they have opportunities and they can see a future, they may not stick with it. So we need to be very proactive in providing that upward mobility. And then the third is the importance of cultural competency training and recruitment. So again, really important that the people that are serving in many of these underserved populations understand the culture in which they're working. They understand the unique challenges and needs, and they're trained to handle them. So those are really the three areas that our report focused on. And what we've been doing is we've invested about $4 million in workforce development initiatives over the last few years. We're providing grants statewide. This allows us to work with community organizations to share challenges, develop targeted recommendations, find strategies to overcome these issues. So we know we can do more. We're really continuing to try to leverage these investments and get more people into this area to help. And we're optimistic that we're focused on the right things, and we have many of the right partners, and we look forward to continuing to grow this.
Yeah, $4 million is a heck of an investment, Brian. That's pretty uncommon for a health plan that health plan that is not also a provider to make an investment like that in workforce development. So kudos to you guys. David, let me ask you about this challenge of recruiting folks who look like their communities, right? Who come from a lived experience that can inform the care that they give, and which usually is you all know better than me, usually leads to better outcomes when the caregivers look like their patients. How does Charles Drew go about finding and recruiting and getting talent into the pipeline, giving people a vision for what they can be as a caregiver, when sometimes those options are hard to find?
Well, thank you. And I was a member of the California Future Healthcare Workforce Commission a couple years ago, and we were really trying to address one of the big challenges in our healthcare workforce policy domain, which is exactly as you're describing, but equity. Shortage areas that are, urban inner city, farm worker communities, rural frontier communities. These are the big challenges, and at CDU, we're actually very able to address these through the pipeline, because that's exactly what we were created to do. Ironically, we don't really suffer for lack of applicants. Students come to us. And I think this is an important message, because they resonate with our mission of serving under-resourced communities. We are a magnet institution for students who are coming into the health professions from under-resourced communities, because they only want to return to those communities to improve the health of the communities, and we are the vehicle for them to do that. And so I think the message here is this can be extrapolated by making sure that our education institutions are really focusing on the needs of under-resourced communities in a greater way.
Janine, what is the role of mentorship? What role does mentorship play in getting people from local communities into roles of caregiver? Did you have a mentor that brought you along? Do you think of mentorship as an active part of your job in your day-to-day?
Oh, most definitely. And I just participated in Mentoring Monday from the Sacramento Business Journal. And so I find mentorship of ultimate importance. It is when someone sees you and kind of taps you on your shoulder and says, hey, I think you can do more. Or when someone reaches out, say to me, now that I'm kind of maybe perceived as kind of having made it, but I cherish it. I think it's a special honor to give back. I think many people who have benefited from having a mentor take that to heart. And it's very important, because I can remember what it was like to be young and to be insecure, but to have a lot of energy, and to have my mentor saying, no, you can do this, or would look out for me and say, hey, you should apply for that position, or you need to go to graduate school. So it's very important to do that. And we have many formal and informal mentoring programs within WellSpace Health, and we do take on students at all levels, all the way down to high school, all the way up through residents, so that we can continue to train and to mentor them, both formally and informally.
Yeah, good. David, I want to turn to your slide now that gets us into the demographic information related to COVID and the vaccine. Why don't you walk us through the slide that you brought?
Sure. And this slide is really taken from the Los Angeles Times. It used data from the California Department of Public Health to produce it. And it's actually a metaphor slide. It's a metaphor for pretty much everything that we want to talk about in terms of healthcare workforce and outcomes in the context of COVID-19. You know, when I'm talking to students, I always say we're too myopic when we look at healthcare problems in the United States, because when we take a world view, we see, of course, the United States spends more than any other industrialized nation on healthcare, but our healthcare outcomes are among the poorest among the industrialized nations. And the reason is we don't get care to the communities that really need it: under-resourced communities, underrepresented communities, underserved communities. And as a result, the healthcare outcomes from those communities drag down the overall performance of our entire country. And so here we have COVID-19 vaccinations, and we have a map of LA County. The map on the green map on the left shows where vaccinations are being given, and the blue map on the right shows where COVID-19 is in greatest prevalence. No surprise, the communities with the highest rates of COVID-19, South Los Angeles, Northeast San Fernando Valley, East Los Angeles, are the communities that are least likely to be receiving vaccinations. The communities with the greatest diabetes poor outcomes are the communities that don't have primary care. And as a result, we see disproportionate amputations. It goes on and on, cancer outcomes, et cetera, et cetera, et cetera. At the top right of the slide, we see two communities that are contrasted. Beverlywood, just south of UCLA, near Westwood, and Commerce in East Los Angeles. Beverlywood has a very low COVID-19 case rate and a very high vaccination rate. In contrast, Commerce, which is primarily an underserved, under-resourced, heavily Latino community, has a very high prevalence of COVID-19 and a very low vaccination rate. This is how things unfold in terms of healthcare unless we take affirmative action to redirect resources to where they are most needed. And I think this is one of the greatest examples coming out of our COVID-19 crisis right now. So thank you very much for the opportunity to present this slide.
This is a heck of a slide, and kudos to the LA Times for pulling this into visualization for us. I want to stick with you for a minute, David, because I know that you have to leave us here in just a few minutes. There's a question from Patrick Pine about the role of immigration policy and being able to both care for and serve communities, particularly communities of color, but also how we can get people into the pipeline. Do you think of things like immigration as part of the pantheon of issues that you deal with?
Yes, there are a number of complexities with regard to immigration and access to healthcare. Immigrant communities are often the most among the most underserved, under-resourced. Whether we're talking about rural farm worker communities or urban areas with a lot of frontline essential workers. These are exactly the communities that don't have healthcare workers and healthcare outcomes to match. When we were doing COVID-19 testing this summer, another immigrant overlay is confidence and trust in the healthcare system. Many people indicated to us that they were often immigrants. They may not have been undocumented themselves, but they had family members who were. And they were reluctant to come forward for testing because they were reluctant to register for testing. They were reluctant to have their data submitted for testing until we made it clear that we were not sharing data And our students come from communities just like the ones that we're trying to serve. And once the community members gain confidence from a immigration perspective in our center, all of a sudden our testing rates tripled on a daily basis. So that's a message about how important it is to actually speak to immigrant communities and to their priorities and their needs in any healthcare context, not just COVID-19 testing.
Before we lose you, sir, I want to ask this other question. I'll ask Janine the same question, and Janine, Brian, and I can spend more time on these slides here after you have departed. But as a white guy who, I grew up in a pretty white community, and I have had to learn my skills of cultural competency, and I still am deficient. What advice, what counsel would you give people who look like me, who want to help address issues like the ones imbued in this slide that you have brought? Where do we start? What advice or counsel would you give folks who want to do something but may not have enough skills or awareness or know where to start?
Well, one of the big solutions is simply making that start. Rolling up sleeves, getting involved in community activities, because under-resourced communities really appreciate resources that come to bear, and it makes a difference. It doesn't really matter who you are as long as you're demonstrating a commitment and appreciation and compassion for the community. And sometimes that could be conveyed through, for example, language fluency. The community members want to recognize that providers speak languages that they speak. That's an important thing. So that's an important first step. So I would say simply by being there, but also recognizing that that everyone has the ability to convey the priorities of these communities. And one of the problems that we have in our healthcare system is that all too often our providers only focus on the patients that are before them. I tell our students, don't just think of the patients that are waiting to see you in the waiting room. Think of all those patients that can't get into your waiting room to see you, who have just as much need for health care. And when you adopt that perspective, you're really advocating for under-resourced communities.
Yeah. Dr. David Carlisle, MD and PhD, President and CEO of Charles R. Drew University of Medicine and Science. I appreciate you being with us, sir. I know you got to sign off.
My apologies. Thank you.
Thanks for doing that. I want to go to you, Janine, on this question, and I know we have to, behind the scenes, we got to kind of do a little bit of tech while we have David depart here. But I want to ask you this sort of same question, because going back to my first slide, you heard a lot of straight people ask non-binary and gay people how to be good allies. I don't know that you hear some of that sometimes, but I think going back to this idea of discomfort, I think that a lot of white people, they don't want to do something wrong. And so they don't know how to ask how to be good, like not just allies, but good humans, how to build an anti-racist institution or community. So what counsel can you give people who are watching, who are, many of whom may be white, or what counsel would you give me in terms of how to be a better human on this?
I think about that a lot, because it is all of us of all colors who have to make some changes. And one of the ones I think is important is the words we do use and the phrases. And so one of them that I teach in our cultural humility class is we no longer say at WellSpace Health cultural competency. When I was coming up and getting trained, I took a lot of classes that were supposed to teach me how to be culturally competent in the Asian culture, in the Chicano Latino culture. And I remember when I took one and it was on the Asian culture, all they talked about was Chinese and Japanese. And I left there wondering, well, what about Koreans? What about Hmong? What about Vietnamese? I'm not culturally competent in them. And then when I watched the one on African Americans, I was like, some of that pertains to me, but a lot of it doesn't. So what I'm starting to hear, and what the way we've changed our language, is to say culturally humble. And what that means to have cultural humility is we can't know it all. And when we don't know, it's best to ask. And I think where I really started thinking about it is just best to ask was when I had the LBGTQ Community Center come and give our staff providers a talk on that new thing we're seeing, the pronouns. Maybe it's not so new, but it was definitely new. I guess it was about 2 years ago, or it was just coming up. And we would see this after people's names, and it was very confusing to a lot of us. So I said, let's talk about it and let's get some education. And what we were left with, it was an excellent presentation, was just to ask, how would you like to be called? Instead of trying to guess or to get it wrong. So I'd say what this applies the same way, is just ask, I don't understand, what you said. Maybe it was an idiom that someone used, or I don't understand this. Can you help me understand? People are always willing to educate, but if you come out and you get it wrong, that is when people tend to get kind of upset. And I would say one more, so that's it, talking about cultural humility instead of cultural competency. And the other thing I would say is, it's great. I would love it for everybody to go out and march or to join a community group to really help. That is like the ultimate. But if you're not quite ready to do that yet, what I would challenge people to do is when you're in your own groups with your friends, and if someone makes like a racial joke, or even something that makes you feel uncomfortable about another group, is to just say something. To even just say, I was thinking about, a lot of these things, and maybe we shouldn't be saying that, or maybe we shouldn't be talking like that. Not challenging them to say that's wrong or anything, but just say, maybe we should be doing something different here. And it can slowly get people to change.
So, Brian, as we think about building a workforce that can meet the needs of this COVID time, post-COVID world that has some cultural humility and fluency, how do you sort of organizationally think about trying to address both the slide that David provided, the inequity built into things like vaccinations versus outcomes, but also in elevating voices? I mean, $4 million that you guys have contributed is a lot. How do you think about elevating voices that might be able to teach us some things about not just this slide, but this cultural humility piece?
Yeah, it's a great question. And I think to sort of build on what Dr. Barris said, as a leader, and with my leadership team, our focus is, we have a focus on a challenge that is both sort of simple and really hard at the same time, which is, we break it down very simply, which is our workforce needs to reflect the people that we serve. And so when you start there, by making sure that when they call into our call center, they're hearing the languages they want to hear, there's cultural competency at that level, because we've hired a team that looks and sounds and feels like the members we're serving. And then you build on that and you say, well, the supervisors for those folks, the leaders of those people, also need to have that. So we need to be building the path for, I apologize, the path for people to be promoted into supervisory positions and leadership positions that reflect our employee base, which reflects our membership. It all sort of builds from there. And so we spend a lot of time and attention on that. And similar to the healthcare workforce challenges we're talking about, you have to put in the extra work up front to identify those candidates that may not just naturally present themselves through, for example, my career contacts. I could reach out and find really good candidates that I know because I've worked with them in the past. We have to go well beyond that and say, hold on a second, who else is out there that we can find that, again, reflects the membership that we serve and therefore reflects the employee population that we now have.
And I should note, again, it's worth saying thank you, Brian, for HealthNet being a sponsor of this. We love these kinds of conversations, but this conversation happened in particular because HealthNet was pushing it and putting wind in our sails, so we appreciate that. I want to go to this next slide. This is one that you've brought to the conversation, Janine. Tell us a little bit about what we see here.
Yeah, this slide just shows some of what that $4 million that HealthNet spent out there that we were the beneficiaries on, and the synergy that we have, and that's the two circles, and how we are not mutually exclusive, how we have to help each other. And so one of the things that we've been a beneficiary of from HealthNet is a grant that provided training for medical assistants. As mentioned before, it can be hard to hire people into an FQHC, and then sometimes it's hard to keep them. And one of the things that we really looked at is the medical assistant. You know, the medical assistant, once you can max out in your earning potential, but we wanted to make it a really great job. And so through this grant, we created a program where medical assistants can train to become health educators. And when they become a health educator, we specifically focus them on diabetic education, because diabetes is very high in our community. And as we all know, if you don't control diabetes, you thereby increase each person's morbidity and mortality. So if we can slow down the damages that happen with diabetes through education, and of course medications and great primary care, but we need health educators who, like you mentioned, speak the same language, who look the same, who can meet people where they are. We have greater or much more improved outcomes in our diabetic management. So not only do we get to create a workforce that's more diverse, more educated, we provide an individual person with a better job, a better career. We also can impact our patients by improving their diabetic control. And another program that was perfect for this time, and I was really excited to have participated in, was the HealthNet's sponsored a 2-day series on implicit bias. And it was amazing, so amazing that I brought it back to WellSpace Health, and we had the same speaker come and provide the same education to us. And along the lines of what we started talking about was, now with implicit bias, we can really have much better conversations than we ever were in the past. Remember when I was much younger, we know the history of what's happened in this country with slavery, with the devastation to the native populations. But there always came a point where you would bring it up, and then you would politely change the subject so as not to make anyone uncomfortable, either someone who was a descendant of slaves like myself, or the white person in the room who might be a descendant of the slave owner. Even saying that makes me feel uncomfortable, but it's a conversation we have to have as Americans so that we can come together, so that I do get to sit here and be the expert and to be the doctor and to have a job of my choosing, and for my daughter and grandchildren on can go on and have this. And that all starts with having these conversations, because especially in healthcare, implicit bias can cause the death of patients. And we see this in the maternal mortality rates. So by having implicit bias training, by having people start to think about what might get in their way of making good medical decisions, it's by stopping and having these conversations. So we're very happy to have been the beneficiary of these grants and these learning opportunities, and then to keep moving forward with these conversations.
Yeah, I love the idea of of an implicit bias training. If your folks could send the contact people to our folks, maybe we could figure out how to do something for the State of Reform community. Elisa Hernandez asks about these slides. Are they available to the public? Yes, we'll make sure that those are part of that they are available. We will take this video. It is recorded. We'll turn it into a story and post it at our site. The links will be there. Peggy Wheeler also has an interesting question that I want to pose to you, Brian. It builds off what Janine was just speaking to. And Peggy asks that, she says, Dr. Barra and Dr. Carlisle and the data have laid bare the disparity in exposure to COVID and the access to care. How do you think increasing the diversity of the workforce would have altered the outcomes we are experiencing now in COVID? If this work that you are doing, Brian, were 5 years or 10 years ago, do you think we would have different outcomes today with COVID?
Wow, that's a great question. It's hard to say that we'd have different outcomes. I think that, obviously it's been a terrible pandemic. Probably a little more equity in the outcomes, right? If some of these workforce challenges that disproportionately hit the underserved population had been addressed. Let's just picture a world where there wasn't that disparity in access to care, quality of care. Then, yeah, I think we'd see more similar results and outcomes across the state.
Janine, what do you think if and when the next big pandemic hits in 10 or 15 years? To Peggy's question, do you think that this will change those outcomes in 10 years' time?
I would like to think so, because we can't. So when we now start talking about it, we start doing something about it. And why do we start doing something about it? Because it doesn't feel good to feel uncomfortable. And we do, as humans, like to avoid that at all costs. And having these communications and these discussions makes us feel uncomfortable, and it builds the need to do something. And that's why you see people of all colors out at the Black Lives Matters marches. Why you can look, if you look at something maybe on Facebook and you think, oh, a Black person might have said it, but it was a white person. When you go to their site, it's fascinating and it's energizing. And when we get to this point, people won't let us go back. There's no way we can go backwards, because the force of will. And I guess I am a true optimist, and I believe there's only one path forward, but I don't think it's going to be easy. I think people are going to fight to keep things in the old way, but I don't believe we can ever stay there, because the greater force, and I think what most people want is for everybody to have a fair chance and equal access. And I don't think it will feel good anymore for anyone to say, I have so much more of everything and other people don't have anything. I don't think we're going to be able to live with that in the amount of people now that so many things have been laid bare. Now it is just I don't care about others. And I don't think many of us, or the average person, feels that way. I think the average person really does care about the other person and wants them to have their fair share too. So I do think in 10 to 15 years, if we find our way again, it won't be as bad as it is today.
This next slide, I want to tee up as we start to near the end of our time together. This slide actually comes from Dr. Ben Danielson, who until recently was a chief medical officer at an FQHC, Odessa Brown Children's Clinic, that focused on underserved populations. And we, in a conversation very similar to this one, this is what he provided. And he called us to think about the longevity of our impacts. That we know that when young girls, when women are born, they are born with all of the eggs that they will carry throughout their life. Of course, those eggs become children as birth moves forward, but those eggs are materialized in the womb of that child's grandmother. In other words, the mother's eggs are made in the womb and created in the womb of the grandmother. So what we do to the grandmothers will impact how our grandchildren, some of their outcomes, not just who they are, but of course how they're treated and their healthcare disparities. So Let me ask you, Brian, first. What are your, we're talking about kind of longevity and the next pandemic and workforce and cultural humility. When you think of, the longevity and how we treat ourselves and our people and our neighbors and the impacts of that over time, what does this slide make you think?
Well, I mean, I think Dr. Carlisle and Dr. Barra, we've all sort of said it, is this pandemic has illustrated very bluntly a situation that already existed, and it's in some ways it's simplified it for anybody that may have been confused about what was happening. And so I think if we're searching for some silver lining in a global pandemic, which is hard to do, I think, as Dr. Barra said, there's no going back. We can't let that happen again, or let that approach and dynamic continue. So I think there's lots of things that are happening. There's efforts to improve access, improve quality. I think telehealth will be the adoption of telehealth will be a wonderful outcome of this. There were providers that were maybe not comfortable with it that are now very comfortable. Patients that weren't so comfortable that are now very comfortable. It's taken root. It's freeing up capacity in some of the clinics that are in these communities now. Some clinics needed infrastructure to get this up and running early in the pandemic. We did another program with the Department of Managed Healthcare and granted $14 million to clinics to get them, buy iPads, get up, let's get running. So I do think that there's some real momentum here that, as Dr. Barra said, it's sort of a situation. Now that you know this, can you really just ignore it and kind of go back to it the way it was? I think the answer is no.
Janine, what do you make of this slide and Brian's comments?
I do think this is it's very profound to think that I'm a woman, and carrying that forward, that's very real. And I combine that with some of the research and understanding that we have about the impact of stress on our bodies, all the way down to the genetic level. And might there be changes made to DNA that we would pass down to our children because of the stresses that we would feel from, say, institutional racism? Is that there's many theories out there that look at maybe Black and brown people have higher rates of hypertension because of the continual stress that we live under, when everywhere you go, you don't know if you will be accepted or you will be turned away, or in the past you might have been beaten. It's an incredible amount of stress. And might there be some changes in our DNA that now we're going to pass on to 3 or 4 or 5 generations? Well, we don't know that right now, but it does make you pause. And along those lines is, that stress, that hypertension, that diabetes. Again, we know that when people get good medical care, preventative medical care, they don't have the bad outcomes. They have fewer heart attacks, fewer strokes. I always say to my patients, I'm a primary care doctor at heart. And so I always say, when you get diabetes, it's like the train has left the station and you're the conductor in charge. And so you decide to take your medicines, change your diet, because that heart attack or stroke is going to happen. Like, we don't get to stay. But you don't want it to happen in your 50s or 60s. It's in your 70s or 80s. And what I'm seeing when I'm working in the community health center setting, as opposed to when I worked at an employer-based insurance, is same outcomes of heart attacks and strokes, but they occurred at a much older age, say 80, 90 in that population. And then in this population, it's happening at the 50s or 60s. Well, that's around my age, and so that's kind of creepy. So to do everything we can to make a difference in that, especially in a pandemic year, the joy, the beauty, the kind of saving grace was telehealth, or is telehealth. We were able to, when patients were told to shelter in place, stay in their homes, we could reach out to them with a telephone call. And these would be robust, and they are still robust visits, where if they had a blood pressure cuff, we would take their blood pressure, and here we'd ask them to weigh themselves. We did intake with the MA, all of the screenings, and then had a complete visit. So no, we couldn't do immunizations or listen to a heart or lungs, but most importantly, for most people, it's that connection with their primary care provider to get to hear their voices in some cases, to reassure them. Again, this is a scary time. And I would say telehealth was not only, of course, very beneficial in primary care and pediatrics to do refills, to order labs, to keep that connection with patients, but also, probably most importantly, it was in our behavioral health programs. Lot of mental health issues right now. WellSpace Health runs a suicide hotline for 53 of the 58 counties in California. And there's a 40% increase in calls. That's just phenomenal, but it just shows you how much stress we're all under. And we were able to reach out and provide care to people using telehealth. And I say this so passionately because it was only given to the FQHC population or community under the emergency order.
Yeah.
And so there's much discussion right now about what the future holds. And I'm very concerned that, again, we're going to end up at an area where myself, as I have employer-based insurance, I have access to telehealth how I want, via telephone or video, but someone in the population I serve, because they're going to an FQHC, won't, and they will again get substandard care. And so we are having these conversations across the state, and I am hoping that what we end up with ends up equitable and provides parity so that the patients that we care for can get the same level of continued care. And anecdotally, our providers say they actually were able to give more care to patients, because one of the reasons they don't come is because of problems with transportation, but now they can give them the care they need. And we have seen actually a decrease in our an improvement in our diabetic control. So decrease in A1C, improvement in diabetic control, even in a time when people are stressed out about something else.
Good stuff. I know we're nearing the end here, and I want to just ask this last question. I'll give you the last word, Brian. I'll ask you first, Janine. What gives you hope right now? What gives you hope at the end of February of 2021? What makes you inspired to keep doing this work?
Not to sound trite, but it's things like this, where we have these conversations on so many different levels, and to know that people are talking about things that are important for improving our community, our society, and that people aren't ignoring it. They're jumping in, asking questions, giving someone like me an opportunity to talk about the work that I do in Sacramento. That's what gives me hope, is because this is why I think we can't go backwards.
Yeah, great stuff, Brian. Yeah, that's right. We better not. We better not. That's for sure. Brian, what gives you hope in February of 2021 as you look forward?
Yeah, I think that's right. I think, to state the obvious, I have hope that we are getting a handle on the vaccination logistics, and that those will begin to flow more freely here in the next, 3 to 4 weeks. And, when I talk to folks and I hear, for example, my kids are really excited to go back to school. That's different. People are really excited to just do the little things, go to a movie, get together with family and friends, things like that. I think we're going to come through this with a renewed appreciation for just a lot of the simple things in life that many of us probably took for granted before all this. So I have hope that the vaccinations are going to be flowing. There's a lot of energy around getting over the hesitancy challenges that we all have. I think we'll be able to do that. And then, people will have just a renewed passion for just silly little things that we've been missing.
Brian Turnan, CEO and President of HealthNet of California, and Dr. Janine Barra, Chief Medical Officer at WellSpace Health. Appreciate both of you guys being here. And of course, also Dr. David Carlisle, President and CEO of Charles Drew University of Medicine and Science. Thanks to him, he had to leave us early. But I want to tell you, we really appreciate HealthNet putting wind in our sails and sponsoring this. And the folks who are watching, thank you for staying with us. Those were great questions. I know there were a couple of people who asked about your implicit bias speaker that you recommended. We'll get that name, we'll put it in the story, and we'll make sure people know about it. So from us here at State of Reform to all of you here, thank you very much for letting us play this role, and take care.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.